Welcome, class, to Chapter 10, Rhythms Originating in the Ventricles, Lecture, Part 1. The ventricles are the heart's least efficient pacemaker. If the ventricles function as the heart's pacemaker, they normally generate impulses at a rate of 20 to 40 beats per minute. The ventricles may assume responsibility for pacing the heart if the SA node fails to discharge, along with the atria, which is the next pacemaker. When the ventricles, which impulses at a slower rate, will now become the main pacemaker of the heart. The ventricles are known as the last resort before the heart completely stops contracting. Rapid ventricular arrhythmias can result in drastically decreased cardiac output, cardiovascular collapse, and then, of course, death. Ventricular rhythms originate in one or more irritable foci in the ventricular tissues below the conduction system pathway. Without the benefit of the conduction pathway to speed the impulses along the tissue, the impulses trudge very slowly, cell by cell, through the ventricle, producing a wide QRS that measures greater than 0.12 seconds. The shape of the QRS complex is influenced by the site of the origin of the electrical impulse. Normally, an electrical impulse that begins in the SA node, atria, or AV junction results in depolarization of the right and left ventricles at about the same time. The resulting QRS complex is usually narrow, measuring 0.2 seconds or less in duration. The impulse does sometimes travel backwards to depolarized atria, but the resultant P wave is usually lost in the mammoth QRS complex. P waves are usually not seen in ventricular arrhythmias, but if they are visible, they have no consistent relationship to the QRS. Because ventricular depolarization is abnormal, ventricular repolarization is also abnormal. The result is changes in the ST segment in T wave. The T wave are usually in a direction opposite that of the QRS. Let me repeat that. The T wave are usually in the direction opposite that of the QRS complex. If the major QRS deflection is negative, the ST segment is usually elevated and the T wave positive, upright. If the major QRS deflection is positive, the ST segment is usually depressed and the T wave is usually negative, invert. Word on the ventricular rhythm. Ventricular rhythms, the most lethal of all rhythms, command great respect from healthcare professionals. They can result from escape or assertion, or can have a heart rate varying from 0 to more than 250 beats per minute. Although some ventricular rhythms can be well tolerated, many will cause symptoms of decreased cardiac output or even worse, cardiac standstill. Some ventricular rhythms have no QRS at all. Others have wide, bizarre QRS complexes. If the rhythms or beat in question meet any of the following criteria, it is ventricular in origin. Criteria for a ventricular beat or rhythm. They can be premature, wide QRS beats without preceding P waves, interrupting another rhythm, or no QRS at all, or cannot be sure if there are QRS complexes, or rhythms that have wide QRSs, which are greater than 0.12 seconds, without preceding P waves. Now we will talk about the different ventricular rhythms that we'll be seeing. The first one we'll be talking about is called a premature ventricular complex, or PVC for short. A PVC, which is also called a premature ventricular extra astole, or ventricular premature beat, or a premature ventricular depolarization, arises from an irritable site within either ventricle. PVCs have the following characteristics. The QRS is premature. A P wave isn't associated with a PVC. Normally, the P wave of the underlying rhythm, usually sinus, is observed within the PVC, but sometimes it appears just before or after the PVC in the ST segment or T wave. The QRS is wide, which is greater than 0.12 seconds, and the morphology is different from the QRS complex of the underlying rhythm. The ST segment and T wave slope in the opposite direction from the main QRS deflection. If the ectopic QRS complex is predominantly negative, the ST segment is usually elevated and the T wave positive. If the ectopic QRS complex is predominantly positive, the ST segment is usually depressed and the T wave negative. The pause associated with the PVC is usually called a compensatory pause. So if we just have a normal PVC, the rate can occur in any direction depending on its underlying rhythm. So its regularity would be considered regular but premature, or should I say regular but interrupted by premature because, of course, PVC, premature ventricular complex, says it in the name itself. There are usually no P waves, so therefore you will not have to solve for a PR interval. Your Q waves, your QRS are usually wide and bizarre in shape, and they'll have a QRS interval of greater than 0.12 seconds. Your T waves will always be the opposite of what your QRS is. So say, as I said earlier, if your QRS is upright, your T wave will be downward or in a negative deflection. Same thing if your QRS is in the downward deflection, your T wave will be in the upward deflection. Some causes of a PVC is due to heart disease, hyperkalemia, hypoxia, hypomagnesemia, medication, stimulants such as caffeine, stress, anxiety. Some adverse effects to a person who's having a PVC is they'll have occasional PVCs, which are of no concern whatsoever. Every once in a while, even a normal person can throw a PVC every once in a while if it's due to a stimulant. But if a person has frequent PVCs, this can progress into something lethal. So occasional PVCs are not really required for any treatment, but if they're frequent PVCs, you usually treat the cause. So you would either prescribe the patient a supplemental potassium, oxygen, disease, or tell them to refrain from any stimulants such as caffeine, tobacco, alcohol, or any other abusive medicine. They will have to have follow-ups with a cardiologist just to make sure if you treat the cause of what's causing the PVC, and so they have to get checked by a cardiologist to see if what's causing the PVCs, once they restricted from them, if the PVCs have disappeared or have become more occasional instead of more frequently. This is if you look on figure 10.3, this is an example of a PVC. This perchance is an example of an R on T PVC, to be more precise, and I'll go into what an R on T PVC is. So as you can see, you start out with some type of sinus rhythm. Then if you take a look at right here, as you can see, we say R on T because just right after the last sinus rhythm, you see your T is starting to form, and then right after that, the R comes in. That's what we call a R on T PVC. All right. So PVCs can sometimes come in pairs or one at a time. So PVCs may occur in various patterns. PVCs can occur infrequently with no identifiable pattern, are called isolated PVCs. When you have two consecutive PVCs, they are called a pair or couplet. So you have different PVCs. You have PVCs that come in a single foci, which all look alike, which we usually call a unifocal PVC. Then you have PVCs that come from different foci, which look different. We call those multifocal PVCs. So if you look at figure 10.4, figure 10.4a shows you a unifocal PVC. And when we say unifocal, if you look at your PVCs, they're both going in the upward direction and they pretty much almost look alike. But if you look at figure 10.4b, excuse me, as you can see, our PVCs, one's going in a downward deflection and one's going in an upward deflection. That's what we call a multifocal PVC, due to the fact that it expresses itself, or it fired off from different foci within the ventricles. So one could have been a left, one could have been a right. The best leads to use for identification of ventricular beats or rhythm is V1 or MCL1. Left ventricular PVCs have an upward deflection, where right-sided PVCs have a downward deflection. Left ventricular PVCs are considered more significant than right PVCs. Two consecutive PVCs are called a couplet. Couplets are also referred to as two in a row or back-to-back PVCs. The appearance of couplets indicate the ventricular atopic site is very irritable. Couplets can either be unifocal or multifocal in how they appear on a rhythm. So on figure 10.5, we have two different examples. One is of a unifocal unifocal couplet. The other one is a multifocal couplet. So as you can see, the uniformly couplet, they appear back to back. That's what makes it a couple. It's a couple. Couplet, couple. So they're both in the upward deflection. Whereas the second one shows a multifocal couplet or couple, which means it's two PVCs back to back, but one is in the upward deflection and one is in the negative deflection. PVCs can be regular at times. If every other beat of a PVC shows up, meaning for every other beat you see a PVC, we usually call that a ventricular bigamy, or bigeminy, bigeminy, meaning two. So you would have a beat, a PVC, a beat, a PVC. So every other beat would show a PVC in it. Sometimes it'll be every third that a PVC appears. We usually call that a ventricular trigeminy. And sometimes you get a beat, a regular beat, a regular beat, a regular beat, then the fourth beat is your PVC. That is usually called a ventricular quadgeminy, and then so on and so forth. If we start to see quadgeminies, that means it's too many PVCs coming through. As the same as a couplet as we do with our bigeminy and trigeminy and quadgeminies, they can also be multifocal or unifocal also. So if we take a look at figure 10.6 of the ventricular. This is a ventricular trigeminy. We really can't tell with the first rhythm, so we really don't look at it. But if you look at the second and the third beats, as you can see, we have 1, 2. Our third beat is a PVC. 1, 2, and our third beat is a PVC. That's what we call a PVC trigeminy. So PVCs usually have a pause, which we will call a complete comprehensory pause. And basically what a pre-comprehensory pause is the measurement from the beat before the PVC to the beat after the PVC, which is equal to 2 RR intervals of the underlying rhythm. The underlying rhythm must be regular to determine a comprehensory pause. A comprehensory pause often follows a PVC and occurs because the SA node is usually not affected by the PVC. The SA node discharges at its regular rate and rhythm, including the period during and after the PVC. A note: it is important to note that the presence of a full comprehensory pause does not reliably differentiate ventricular ectopic from atrial ectopic. This is because atrial ectopy may produce a similar comprehensory pattern if it does not reset the SA node. So, this is what we call a complete comprehensory pause. If you take a look at figure 10.7, as you can see, your R to R intervals or your RR cycles are there, and then you have a PVC that happens, which is a premature beat. But if you see from this R to this R, this R to this R, we have, if we measure it out, we count the little blocks and we take out the PVC, we'll see another R will appear right here. That's what we call a complete comprehensory pause, because if we take the PVC out and replace it with a regular R to R interval, we'll see it would have pulsated out if the PVC hadn't appeared. Fusion beats. This is another particular type of PVC. Fusion beats is the result of an electrical impulse from a supraventricular site discharging at the same time as an ectopic site in the ventricles. Because fusion beats are a result of both supraventricular and ventricular depolarization, these beats do not resemble normally. They resemble true ventricular beats. Some fusion beats will look more like the sinus beat, just a little wider or taller or deeper, and others will look more like the PVC but narrower. Fusion beats are caused by the same factor that causes PVCs and are treated with the same way. So fusion beats are formed whenever a sinus impulse and a premature ventricular impulse arrive at the ventricular tissue at exactly the same time. That's what we call a fusion beat. It's a merger. It's like when the sinus and the ventricular get together and they produce an offspring, which is the fusion beat. The shape of a fusion beat can either be between a sinus beat or it can be more to a PVC. So just imagine the sinus beat is the mother and the PVC is the father, and the fusion beat is the offspring, which can either look like the mother or the father, same as when we have children. They either look more like us or they look like their father. So this is on figure 10.8 is an example of a fusion beat. As you can see, we are trudging along and we have a sinus rhythm. And if we look here, kind of looks like a sinus rhythm because why? And I'll highlight it in a different color. Let's go with yellow. Look, we have a baby P right before our PVC. So in this particular first example of a PVC, it looks more like a sinus rhythm, but it's not. It's a fusion beat because that's a PVC. So let's take a look at this one, this fusion beat. Well, this fusion beat looks more like a ventricular rhythm due to the fact that there is no P. So it looks more like the father than it does the mother, whereas the first one looks more like the mother than the father due to that hidden little P right before the PVC forms. Those are what we call fusion beats. When they take a characteristics of whatever the underlying, they either take a characteristics of a sinus beat just wider or a ventricular beat just wider. It's a PVC. The next rhythm we'll talk about is the Agonal rhythm, or we call it sometimes the dying heart. Agonal rhythms occur when essentially all of the pacemakers in the heart have failed. This is the last electrical activity in the heart. The heart is basically dying. This is like its last little leg that the heart is going on before it just gives up and stops contracting. The impulses shown on the monitor are less than 20 beats per minute. This dyrrhythmia presents with wide and bizarre QRS complexes, which are greater than 0.12 seconds, and an absence of P wave. So the rate is less than 20 beats per minute, although an occasional beat may come in a slightly higher rate because the heart is not giving up just yet. As long as your body is trying to pump out blood in and out through it, your heart will still try to fight up until it can't go anymore. Regularity is usually irregular because it is at a very slow beat and your heart is dying. So your impulses may come in at different levels. There are no P waves, so therefore you don't have to worry about a QRS. And if you do see a QRS, um, I'm sorry, there are no P waves, so therefore you have to worry about a P or interval. And your QRS, when you do see them as far as they are usually wide and bizarre, and the intervals are greater than 0.12 seconds. And as always, your T waves will be the opposite of whatever your QRS is. So if your QRS is in the upward deflection, your T wave will be negative. And if your QRS is in the negative deflection, your T wave will be positive. Some causes of an alcohol is the person is dying, usually from profound cardiac or other damage or from hypoxia. Adverse effect of profound shock of consciousness, death if untreated. An algorithm usually does not provide a pulse, or even if it does, the cardiac output it produces will be in, incompatible with life or incompatible with life, meaning that sometimes it might get missed because it's so weak you can't really tell if there's a beat there at all because the heart is dying and there's no cardiac output to get it started. So treatment for an algorithm is to start performing CPR. They might give you an epinephrine shot or atropine or oxygen just to help get your heart to get started again. Right. And this is an example of an Agonal rhythm. If you look on figure 10.9, as you can see, your QRSs are really spaced out because the heart is about to give up. Right. The next rhythm we're going to talk about is the Idioventricular Rhythm, or IVR. IVR, which is also called a ventricular escape rhythm, exists when 3 or more ventricular escape beats occur in a row at a rate of 20 to 40 beats per minute. The QRS complex seen in an IVR are wide and bizarre because the impulses begin in the ventricles and bypassing the normal conduction pathway. IVRs may occur intermittently or as a continuous beat. Intermediate IVRs often occur in short runs of 3 or more consecutive ventricular beats and is usually related to increased vagal effect on the SA node, allowing the ventricular focus to take control for a temporary period of time. Treatment is usually unnecessary, but continuous IVRs usually occur in advanced heart disease and is commonly the cardiac rhythm present just before the appearance of the final rhythm, ventricular standstill or ASTOL. If the rate of an IVR falls below 20 beats per minute and the QRS starts into irregular, wide, and indistinguishable waveform, the rhythm is commonly referred to as an irregular rhythm or a dying heart. Treatment is usually ineffective at this point. A ventricular escape rhythm, or IVR, may also occur as a result of an acute coronary syndrome, digitalis toxicity, or metabolic imbalances. Because the ventricular rate associated with IVR is slow, with a loss of ventricle, the patient may experience serious signs and symptoms as a result of decreased cardiac output. If the patient has an impulse and is symptomatic because of the slow rate, treatment should include applications of a pulse oximeter and administration of supplemental oxygen if indicated, establish intravenous access, obtain a 12-lead EKG, and administer IV atropine. Sometimes a transcutaneous pacing or a dopamine or epinephrine or isoproline IV infusion may be tried if atropine is ineffective. Medications such as lidocaine should be avoided during the measurements of this rhythm because lidocaine is an relaxer. May observe ventricular activity, possibly causing asystole in a patient with a ventricular escape rhythm if the patient is not breathing and has no pulse. Despite the appearance of organized electrical activity on the cardiac monitor, EPA exists. The management of EPA should include cardiopulmonary resuscitation CPR, giving oxygen, starting an IV, possible replacement of advanced airway, and an aggressive search for the underlying cause of the situation. Right. So the characteristics of a IVR are simply this. Your ventricular rhythm is essentially regular. If you look at it, it is a regular beat. If you look at figure 1010, it is essentially regular. The rate is anywhere from 20 to 40 beats per minute. Your P waves, there aren't any at all. There's none. So therefore, you don't have to worry about calculating your P or interval. Your QRS, as you can see, are wide and bizarre, so therefore your QRS interval will be greater than 0.12. But if you look at the example on 1010, as you can see, your Q is upright in this example, but look at your T wave. It's in the negative deflection. So your Q and your T will still be in the opposite deflection of each other. The next rhythm we'll talk about is the Accelerated Idioventricular Rhythm, or AIVR. And this is be the last rhythm we'll talk about today. An accelerated idioventricular rhythm, or AIVR, exists when two or more ventricular beats occur in a row at a rate of 41 to 100 beats per minute, or 40 to 100 beats per minute. Some cardiologists consider the ventricular rate range of an AIVR to be 41 to 120 beats per minute. This is according to the cardiologist's point of view. An AIVR is usually considered a benign escape rhythm that appears when the sinus rate slows and disappears when the sinus rate speeds up. Episodes of AIVR usually begins and ends gradually. It is also called a non-paradoxical VT because it starts and stops so suddenly. And remember, paradoxical is the start and stop of suddenly. An AIVR can be called a non-paradoxical VT. Fusion beats are often seen at the onset and end of the rhythm. So sometimes you might see a fusion beat within an AIVR also. AIVR is most commonly seen during the perfusion phase following an acute myocardial infarction. It is often associated with increased nasal tone. Other causes include electrolyte abnormalities, cardiomyopathy, congenital heart disease, myocarditis, and digitalis toxicity. So, as you can see, excuse me, AIVRs has been observed in patients with the following. They have acute myocarditis, cocaine toxicity, digitalis toxicity, diluted cardiomyopathy, hypertensive heart disease. Some causes of a person having an AIVR heart rhythm. Treatment for an AIVR with antiarrhythmics is not recommended. Abolishing the ventricular focus may lead to a less desirable rate in rhythm. This rhythm is usually transient, requiring no specific treatment, and spontaneously resolves on its own due to it is a non-paradoxical routine, meaning it starts and stops on its own. Taking of time is most often the best remedy, meaning monitored and within time, an AIVR will essentially be out on its own. So the characteristics of a known AVR, if we take a look at figure 1011, we can go through the characteristics. As you can see, it is basically a regular rhythm. And if we count out our little blocks, the rate is anywhere from 41 to 100 beats per minute. There is no P waves, as you can see on this example. Your QRS duration is going to be greater than 0.12 seconds, and your T waves are in the opposite direction, which yes and yes, as we can see. And probably if we look, so this concludes our lecture for today. This is part 1 of chapter 10's lecture. We talked about the different types of PVCs we may come across. You might have a normal PVC, you might have a unifocal PVC, multifocal PVC. You might see a compensatory pause followed before and after a PVC. You might see a fusion beat PVC. You might see an R on T phenomenon where your PVC is right next to as soon as your T wave forms on your normal underlying rhythm. You might have a couple or a couplet. whether it's two PVCs back to back, and they can be either unifocal or multifocal in standing. You might have a PVC that shows up every other beat, which would be a bigeminy PVC. Or you might see one that appears every third beat, which is a trigeminy PVC. And then you might see one every fourth beat, which is a quadgeminy PVC. Then you might see an Agonal rhythm, which is basically your heart dying, where your QRSs are spaced out so far in between that your heart rate is less than 20 beats per minute. Then you might see your Idioventricular Rhythm, or AIVR, where your beats are anywhere from 20 to 40 beats per minute, and your QRSs are wide and bizarre, and your T waves are deflected in the opposite direction of your QRS. And then you have AIVRs. If anyone has any questions, please feel free to text or message me through Emeto or through my cell. I hope you enjoyed this lecture, and I'll talk to you in Chapter 10, Part 2. Thank you and have a nice day. Bye-bye.